Hello and welcome to Kauai Health's monthly community engagement webinar. I am joined today by Gary Herbst, our CEO, and we're going to talk about a few things. We're going to talk about those FEMA funds that we have been chasing for over 2 years now, and then lots of things going on at Kauai, and people are curious to know why people are running around on a sequoia at the convention center.
Dressed in costumes sometimes
Yes.
too.
And then, of course, we're going to speculate on some upcoming legislation and some things that are getting ready to happen for the state of California. So, like we always say, feel free to chat in if you have any questions, and Daniel will get those to me. But Gary, welcome. Let's go ahead and start.
Yeah,
Welcome
thank you.
we didn't do this last month because we had a conflict, but welcome back.
Okay, really? We didn't do this?
No, we didn't.
Huh, okay, Daniel's shaking his head as well. Okay, all right, I believe you. Just
No,
the
he
days and
didn't
months
believe
just...
me. He didn't believe me. Daniel had to shake his head in order for Gary to say, "I
That is
believe
not
you."
true.
I'm not offended, I
always
promise.
believe you. Okay, well, it's good to be here. Yeah, you got any questions for me?
I do.
Okay,
I do.
I'm ready.
Oh, for this? Okay.
Oh, unless you have other questions.
No, I
Okay.
don't. Okay, so do you ever feel like, did you watch the movie Jerry Maguire?
Yes.
Okay, where the guy's yelling,
Show me the money."
me the money.
Yes.
Because I feel like as a staff person, for over 2 years, we've been saying, we're getting it, we're getting it, we're getting it.
Right.
Then our community says, are you getting it, are you getting it? And we've been talking about this a long
I know.
time.
Way
and
too
I
long.
and I
Way
feel
too
like,
long.
are there shenanigans going on with the state of California?
I think there are. I think they are. So yeah, it has taken us an incredibly long time. Something we've been working on at least 2 years, and I want to commend Melinda Tupper, our Chief Financial Officer, and Jennifer Stockton, our Director of Finance. Just the incredible amount of work that they accomplished to complete our application to FEMA, which went through an unbelievably rigorous, comprehensive review, literally being handed from one department to another to conduct their own reviews. And then it finally made it to the state of California. I didn't realize that the state is actually responsible for the final analysis to determine whether you qualify for funding or not. And then ultimately, the money is sent by the federal government to the California Office of Emergency Services, or Cal OES, who makes the final determination and actually writes the checks. Not a wire transfer, paper checks. That is the only way they'll pay you. So we fully expected to have received the funds by now, but as of today, we still have not received the funds. Now, we fully expect that eventually we will, and I've got some breaking news that I just got last night to share with you to respond to your, is there some shenanigans question going on. So when we do get the money, and I don't say if, I'm confident that it's a when, $47 million. The first thing we will do is use about 10 million of that to make our employer match to our employee 401k plan for the calendar year 2024. So that'll be about 10 million will come from that. And then the other remaining 37 million, we are going to put back into our cash reserves, which have been significantly depleted over the course of COVID. As I've shared with you in the past, I think cumulatively over the 4-year period, I'll say, of COVID, we incurred operating losses of about $150 million. And so we were funding all of those operating losses using our cash reserves. In fact, at our lowest point, our number of days cash on hand, which essentially means how many days can you cover your average operating expenses before you run out of cash, well, it dropped all the way down to 62. I'm excited to say that we're back up to about 95 right now, but that while that's now above our bond covenant that requires that we can never go below 30, 90 days. And if you go below 90 days, you're not technically in default of your debt, but you are in non-compliance. And which is also what resulted in the downgrade of our credit rating. So we're back above that 95, but we are significantly below the roughly 170 days cash on hand that we were consistently maintaining prior to COVID, which allowed us to maintain a A rating from a credit worthy standpoint by Moody's, which having an A rating is really important when you need to borrow money for new projects, new facilities, new equipment. Having an A rating means there's going to be a big appetite for your debt, and you're going to be able to get it at a very low interest rate. As your credit rating drops, fewer and fewer people want to lend money to you, and you generally have to pay a much higher interest rate because you're a riskier borrower. So we'll put the balance of that money back into cash reserves. So, but as I said, we still have not received it. When I opened up my email from Cal OES last night, expecting great news like, hey, we're about ready to send you your check. Here is what the email read. It says, "Good afternoon. Due to the high volume of obligations we have received from FEMA, the financial processing unit is experiencing delays in our processing and review times. I can confirm that the payment is currently in the queue for review for the reference project. Unfortunately, I am currently unable to give you a time estimate for when this will be completed. We are working to process all obligations and payments that we have received as quickly as possible in the order they have been received. You will receive a notification of payment letter when payment processing has been completed. We thank you for your patience during this time, and if you have any additional questions, please feel free to reach out." Well, I don't think it's any coincidence that last week on May 14th, Governor Newsom released his revised, updated proposed budget for the coming fiscal year. Back in January, he released for the first time his initial proposed budget, and then every year he comes out with what's called the May Revise, where between January and the middle of May, he's been working with his staff, he's working with legislators, trying to refine, he's looking, at his assumptions, he's looking how tax revenues are coming in, how spending's occurring, so that he can shore up, what that budget might look like. Well, his revised budget currently shows a $12 billion budget deficit for next year. That will start on July 1. So he now has between the middle of May and June 15th to work with the legislature to essentially close that $12 billion budget deficit. Well, one way you do it is you hold on to your money as long as possible so that you generate those interest earnings that you can put in the general fund. So $47 million is a lot of money, and we're not the only recipient of funds of that magnitude. Community Regional Medical Center has a $100 million claim. I don't know where they are in the FEMA process. I don't know if they're in that check write queue. But the more and more that the governor can hold on to, the higher the investment earnings. So I think this has a lot to do with that. And also a little bit later, I'll talk about some of the other dastardly things that he has up his sleeve to help close that $12 billion gap. I'm not bitter.
I just think it's interesting. Everybody else has to pay their bills on time, right?
Yeah,
right.
Or bad things happen,
because we could
right?
hold our own money, we could hold our
Yeah.
taxes. We could hold anything that
You
we
think
have
I
to
could
pay.
send a similar letter to
Yes.
my mortgage company?
Dear mortgage,
my auto loan.
I would like to make
yeah.
interest on my money.
Unfortunately, I must inform you that I'm not going to pay you just yet.
Right.
Yeah.
That's irritating.
I know.
Well, we are anxiously awaiting it, and one day we will celebrate
Yes.
when we receive it.
Yes.
But
we will.
thank you for telling us where it's going once it's received. All right, so the question was, I'm seeing a lot of Kauai Health people walking up and down a Sequoia around the convention center. What's going on? And then there were ambulances there the other day, I think the same day that we had a big leadership meeting.
Yes.
And so they're
Yeah.
like, what's going on? So tell us what's been going on.
Lots going on. So the first thing is, so every year we hold an annual competency fair, is what we refer to it. And roughly 1,300 of our registered nurses and our licensed vocational nurses, and I'll say pre-COVID. So pre-COVID, every year, those roughly 1,300 bedside nurses would participate in a week-long competency fair where they would engage in person with our clinical educators and other clinical nurse leaders in the organization to demonstrate that they had the skills and the knowledge and the education and the competency to safely take care of our patients, to perform all those different nursing tasks that are carried out when we're taking care of our patients. So drawing blood, inserting IV lines, inserting catheters, caring for wounds, dispensing medications, the multitude of different things that nurses perform during a patient's stay with us. So we're required under California laws and regulations that we annually assess and evaluate the competency of our nurses, our caregivers. And when we determine that a nurse needs additional training, they're provided that on site. And we always tried to make it kind of a fun event. So a lot of times there'll be a theme that they're following. So unfortunately, when COVID hit, we could no longer do the in-person competency fair. So it all went to online, to virtual. Maybe some things were done in the individual departments themselves, but a lot of it had just gone virtual, like we saw in schools, unfortunately. And we missed that in person, and I think it also it kind of diminished the effectiveness of having to go online, because a lot of that competency, we actually, it's hands-on. You're actually showing our instructors that you know how to do this. So you're demonstrating your competency. So we found or felt that it was the time that we could return to in-person evaluation and competency testing. So Shalene Pete, who is our interim chief nursing officer, she's been with us for about 3 months. So she sat down with her clinical educators or nursing leaders, and they put on their creativity hats, and they created this amazing competency fair, and kind of a takeoff to our vision statement. So our vision, our long-term goal that you're on this constant journey to achieve, is to be our community's world-class healthcare choice for life. And so Shalene and her team took that world-class theme, and they said, wouldn't it be fun to do something around the world, healthcare around the world? And so usually we'd be holding our competency fair down in the basement of our east wing of the hospital, what we called the East Expansion that opened back in the early 90s. Well, down in the basement, we had our large auditorium called the Blue Room, because the carpet's blue, the walls are blue. But that's where we'd hold our big meeting, holds over 150 people. But unfortunately, during COVID, our laboratory commandeered all that space. In fact, that's where they set up the special PerkinElmer's PCR testing for COVID, and so now they have permanently exercised squatters' rights or something. But So Randy Coca and our laboratory, and necessarily, are taking over that blue room to expand. We have a brand new blood bank, some really phenomenal state-of-the-art laboratory processing equipment, so they needed more room. So Mark Mertz and Kevin Morrison are currently working on developing new auditorium space, but it won't be available for maybe a year or two in the future. And so we are renting space at the Visalia Convention Center up on the second floor, and have turned 3 of the rooms into our world-class competency convention, so to speak. I had a chance to walk down there on Monday when it's week-long, started on Monday, and you walk into one of the rooms and you feel like you're at the World Fair. I went to Paris, I went to Germany, I went to
Did you go to Tokyo? Because that's where patient experience was.
Is that right?
Yes.
I think I did.
You probably did.
I think you were right next to Paris, weren't you? Maybe?
Yes, yes.
Yeah.
Well, yeah.
Serving
that's good
croissants
memory.
and
Yeah.
macarons and
Mhm.
so all of our different nursing departments and functions kind of picked a country or a city somewhere in the world, and they've adopted their culture, wearing their clothes, serving their foods, imitating their languages. But it's been a lot of fun. All of our staff rotating through there, learning different education, again, testing competencies. But after you pass through there, you go down the hallway to the next room where there are tables and there are clinicians there, actually evaluating your insertion of a peripheral line or a central line or drawing blood, and so it's been exciting. I think you could definitely tell people were having a lot of fun, but they're also taking it very, very seriously too, because we want to make certain that we're providing, only the highest quality and safety of the care we provide to our patients. So that'll wrap up tomorrow. So that was Monday to Friday. And then our leaders. So we have about 170 leaders in our organization. Our executives, our directors, our managers, our supervisors. Every month we gather for our monthly leadership team meeting that again used to be in that same blue room prior to COVID. Had to go virtual during COVID, but last, I think it was in the fall, we decided that we really need to get back in person. Just that engagement, the interaction, just so much more effective in person, being able to just interact with your peers, connect with people, be able to engage in dialogue, because those leadership teams are where we, I generally lead them as the CEO, but then I have people like Deborah, that's up informing all our folks how we're doing in patient experience, teaching our leaders, tools and practices to elevate the patient experience, and everything we learn as leaders, we try to cascade down to our staff to really impart that information, that knowledge, things that are going on at Cahuilla, new services, expanded services, new policies that we're enacting, new best practices, things of that nature. And so working with the city, working with Leslie Cavilla, we now are renting temporarily a big room at the convention center. So I think it's the third Tuesday of every month. It was this week on Tuesday, and that's why you saw a lot of folks, Cahuilla folks, walking down Sequoia Avenue from the hospital down to the convention center, was for that meeting that took place from 9 to 11 this week. And then lastly, we also saw a lot of folks there from American Ambulance and other first responders. So this is National EMS Week, that across the nation, communities are celebrating their emergency medical service folks. So paramedics, fire men and women, firemen and firewomen, fire persons, where we celebrate and honor and recognize the incredible service and safety that they create in our communities. I looked it up just real quickly. So President Gerald Ford authorized National EMS Week back in November 1974 to recognize EMS professionals' efforts and dedication to saving lives, preserving public health, and providing safety and support to their communities. So today, in fact, Cahuilla Health is hosting its annual barbecue that we hold right out near the helipad and our ambulance bays out in kind of the east parking lot. Every year, unfortunately, I was not able to attend this year, but every year I've really enjoyed being there and serving our fire and police and ambulance and EMS and all of our first responders. We don't limit it just to paramedics and firefighters, but also all first responders. We welcome them. Also, folks from our emergency department who are really first responders as well. So I missed that today, but I hope we had great attendance and the opportunity just to honor and thank our local first responders for their incredible work, and just want to thank and congratulate all of them as we celebrate across the country EMS Week.
Yeah, EMS, it's a big time partnership with us, because what people may not know, and I know I didn't know this, but they don't just drop off patients and leave, but those EMS workers stand by those patients in the hallways until they can be onboarded.
Yes.
And our numbers our volumes are so high in the ED, and especially during COVID, sometimes they were with them
Absolutely.
for a long time. So it's not just getting them here, but they also stay and care for them until we can bring them
Yeah,
home.
I round in the ED as often as I can, and it's not uncommon to see 8 to 10 ambulance gurneys and the ambulance, the EMS paramedics that stay with their patient. Oftentimes they're continuing to provide care until we can officially take responsibility of the patient. The EMS needs to attend to that patient and provide the care to them. So yeah, they're very known to us. They almost feel like they're a part of our team, because they work, again, very closely hand in hand with our nurses and our doctors. They know each other well. So yeah, we appreciate them very much.
Yeah. Okay, so there is a lot of information, a lot of things being shared about the future of Medi-Cal, Medicare programs here under this new administration. And so the question was, the administration keeps saying they're not going to touch Medicare or Social Security. They're only wanting to deal with fraud. Okay?
And abuse.
And
fraud,
abuse.
Waste, and abuse.
Fraud, waste, and abuse. Okay. So then the other side says they're cutting everything and it's all doom and gloom. Okay. So we have talked in the past about the weird way, and you have shared it several times with the community group, about the weird way that the state will hold Cauilla's money. And I'm trying to think of the program. I'm sorry, I'm drawing a blank. So they take it from us, they hold it, then they submit it to the federal government, right? Then the federal government matches it. Then the state will take a portion of that money as their holding fee, and then they will give us back our money. And so the question is, isn't that practice a form of fraud?
You described it
Did I
well.
do it well?
So
Okay.
You've been listening well. Yeah, it's interesting. So what Deborah is referring to, there's a couple different ways that it happens, and it's not unique to California. It's not unique to Cahuilla. In fact, 49 of the 50 states in the country use what they call provider tax or intergovernmental transfers to create additional Medicaid funding. And so what Deborah was describing, and I don't know if I use the word weird, but maybe that's appropriate. And so as a public hospital, as a district hospital, like the other public hospitals, all of the University of California hospitals, UCLA, UC Davis, UC Irvine, UCSF, those are public hospitals as well. As are county owned and operated hospitals, those are public hospitals. District hospitals are also public hospitals. So as public governmental hospitals, we are allowed to take our non-governmental revenues that we receive, which largely come from commercial payers, Anthem Blue Cross, Blue Shield, Aetna. We can't use Medicare monies and we can't use Medi-Cal monies, but we can use non-governmental monies, which are in the hundreds of millions for us, and through a program approved by both the state and the federal government. So it's interesting, and I will talk about the characterization of it as fraud. To me, fraud is something you're doing deceptively, dishonestly, usually secretly, trying to get away with something. These programs that we've been put in place have all been blessed and formally approved by both the state government and the federal government. So we would not be doing them without their permission and their lawfulness, which they are lawful under current law. So we, as a district hospital, as a governmental hospital, we will send money to the state, as Deborah described. The state will accept that money and then place it in its general fund, and then turn around and essentially recharacterize it as Medi-Cal funds. Now, you know that the Medi-Cal, or Medicaid in every other state, but called Medi-Cal here, is a matching program. Medicare for the elderly, 100% funded by the federal government. Medicaid for the poor is a shared program funded by the federal government and the state government. And that share varies state by state throughout the country, and it depends on the wealthiness of the state. States like California and New York that have a higher median income that their population is generating have a lower federal match. Very poor states, like the state of Mississippi, have one of the highest federal matches. So in California, it's 50-50. And so when CWIA gives this money to the state of California, the state then uses that as its state share. And then it reports that to the federal government, who then matches it dollar for dollar. Sometimes the state then scrapes off an administrative fee that they keep for themselves and then remit the balance back to CWIA. Sometimes we get it all back. But that's called an intergovernmental transfer.
Can I ask a question?
Yes.
Okay, so you said we send in non-Medi-Cal, non-Medicare funds.
Yes.
Okay, then when the state gets them, they recharacterize them as Medi-Cal, Medicaid funds.
Correct. But now they're not necessarily, they don't know the source. They don't know, they know that we're not using governmental funds, that we're using commercial or we can use revenue from the lifestyle center, the cafeteria, other sources.
There's just a certain amount you have to give.
There's a certain amount that we're allowed to give. So there are caps, there are limits that are established by the federal government. So we couldn't just say, hey, we're going to send the state $100 million so that we could get $100 million match from the feds. We are limited by a formula that is calculated by the federal government in terms of how much the state can do under this particular program to get matching funds, and then how much each individual public hospital can get. So CWIA, we receive a letter, and there's various programs now that have been created over the years. The same ones that the UCs and counties participate in, district hospitals are now participating in. And each of those programs has a statutory limit in terms of how much the federal government is willing to fund of that. And they're determined by actuaries, they're determined by formulas. One's called the upper payment limit. It's very complex, but we'll get a letter that says, CWIA for this year's governmental match program, you qualify for $9 million. And so we will send that $9 million to the state based on this letter, and then they will match and send back 18 million to us, or maybe a little bit less because they want to keep some of it.
Yeah, so and I wasn't saying Kauai is doing anything, or it doesn't sound like Kauai is, but then when the state takes those non-Medi-Cal Medicare funds, characterizes them as Medicare Medi-Cal funds, and then gets the match, and the federal government's totally aware of all of this. Yeah,
Absolutely.
Yeah.
And again, 49 out of 50 states do this.
Right,
So
right.
it's not unique to California. Now, there's another, so that's intergovernmental transfers, and only governmental hospitals can do that. But there's another program that all hospitals participate in, and that's called the Quality Assurance Fee in California. So voters passed Proposition 52 a number of years ago that allowed all 400 hospitals in California to tax themselves, to assess a tax on their revenues. So not an income tax, it's called a provider tax. And it works just like those intergovernmental transfers I just described. So St. Agnes, Valley Children's, Adventist Health, Community Regional Medical Center, every year they impose a tax on themselves, and they remit that tax to the state government. The state then similarly turns that into a Medi-Cal payment, draws down on federal matching funds, comes back to the state, and then distribute that to all the hospitals in California. And it's a way to augment the Medi-Cal reimbursement that goes to hospitals, which is some of the lowest in the country. The state of California spends the least amount per Medi-Cal beneficiary than just about any state in the country. There's a minimum requirement by law that states must spend on their Medicaid program. And there's a floor, there's a minimum, and California is at the minimum. Other states are more generous and use more of their general fund. There are some states that actually put up the state share of that match. So instead of getting the money from the hospital for the state's portion, the state of Texas will use its general fund to create that additional Medi-Cal or Medicaid funding for its hospitals. So they don't ask the hospital to put up the money and then flip it into a Medicaid.
Mm-hmm.
They actually put up the money themselves.
And then just get the money?
Yes,
Yeah.
but
Wow.
not in California. But I'm grateful for the California legislature and the governor. These programs would not be available without their help and approval.
Mm-hmm.
And so they have done that for hospitals. But what, so last night, the Republican-led House of Representatives, on a vote of 215 to 214, passed the big beautiful budget bill. There were 3 Republicans, every single Democrat voted no for the bill. 2 Republicans voted no, and 1 Republican abstained, which made it a 1 vote difference, that 215 to 214. But all it takes is a simple majority. And so there are many proposed cuts to Medicaid. I think they are estimated to total close to $715 billion. There also is a potential significant cut in Medicare funding that could be triggered. And so I thought I'd hit on just some of the big ones. The one that everybody has probably been hearing about is the work requirement. So Medicaid was originally designed for families and children, pregnant moms, families and children. It almost always excluded single male adults. But the Affordable Care Act, which went into law in 2010, states could voluntarily expand their Medicaid programs. Interestingly, California was one of the very first to expand its Medi-Cal program under Governor Schwarzenegger. He signed it into law in California. And what it did is it increased Medi-Cal eligibility from, you had to be at or below the federal poverty level. So it increased that to 138% of the federal poverty level to be eligible. And it also, for the first time, allowed single young men to enroll in Medi-Cal. So what this new bill, this budget bill, will require is that all able-bodied men between a certain age to continue to be eligible to receive Medicaid or Medi-Cal benefits, you have to work at least 80 hours a month. And if you do not, then you will be disenrolled from Medi-Cal. So the government is expecting that a lot of current Medi-Cal beneficiaries will not qualify. They will either choose not to work and therefore lose their Medi-Cal, or they will not work the required number of hours and they will lose their Medi-Cal. Or maybe what they're hoping is they will get jobs and now have employer-sponsored insurance. So this directly affects hospitals and doctors, and it is projected to potentially save the federal government $280 billion a year, or no, excuse me, over a 10-year period. $280 billion over a 10-year period, and it will go into effect on January 1, 2027. That was one of the concessions it was proposed initially to go into effect in 2029, but the ultra-conservative Republicans really were pushing harder for more cuts, so they convinced them to start it earlier, so January 1, 27. This will save the state of California money, and there will be no more federal match for those people that are no longer eligible to receive Medi-Cal. But what will happen is those that don't get full-time jobs with health benefits, they will once again become uninsured, and they will continue to come to the hospital uninsured, and the hospital will now absorb the cost of providing that, but now certainly the federal and state governments will save money. The thing that causes us the greatest concern, and this is what we've been talking about, is that this bill bans new or increased state provider taxes and tightens standards for what provider taxes can be used for. It also bars most states from using self-directed payments to order Medicaid managed care companies to pay providers more than 100% of Medicare rates. So what does that mean? Okay, so that quality assurance fee that right now that is funded by this provider tax. The good news is that this bans new or increased funding. So it seems to be indicating that programs that are already in place can continue for the next 10 years. So that's a really good thing. But it will not allow providers to increase those provider taxes now over the next 10 years, which, you know, obviously we would love to be able to do that to keep up with inflation. The cost of staffing, the cost of benefits, the cost of supplies and drugs, they go up every year. We're budgeting in our budget this coming year an across the board increase of 3% in supplies and medications. But if we're not allowed to increase those provider taxes to stay, you know, in step with those cost increases, then we'll continue to widen that gap. So this would not allow any increase. What concerns me the most is that this directed payment program. So it was just a couple years ago, I was celebrating with all of you that for the first time, district hospitals were now, a new program went into effect on January 1, 2023, called the District Hospital Directed Payment Program. Again, the UCs and the counties have been enjoying this for years. So, but for the first time, district hospitals could have directed payments. It's another one of these programs where district hospitals put up this intergovernmental transfer. The state turns around, calls it a Medi-Cal supplemental payment, draws down on that federal matching fund and gives it back to hospitals, but it comes through the Medi-Cal managed care fund or plans. So that program for district hospitals started out on January 1, 23, providing $200 million a year for us 33 district hospitals. On January 1, 25, that went to $800 million for us 33 district hospitals. It means about $40 million a year to Cahuilla. We won't actually see the funds for 2 years, but we're earning it now. And so that's still a huge benefit to us. What this is suggesting is that we can still have that program. We can't add any new programs. We can't grow or increase the existing program, but they're now stating that those funds cannot result in hospitals receiving more than what Medicare pays us for those same services. That $800 million that was put into place on January 1, 25 increases Medi-Cal reimbursement rates to hospitals and doctors significantly above Medicare rates, and which is a dream come true, that Medi-Cal would actually become our single best payer. Commercial insurance has always been a hospital and a doctor's best payer, often subsidizing the losses that we as providers incur taking care of Medicare and Medi-Cal patients. Medicare actually pays only 75 cents on the dollar. So it does not cover the full cost of providing care to Medicare patients. But for the first time, because of these new supplemental programs that are funded by provider taxes and these intergovernmental transfers, actually fully covers the cost of providing care now to the Medi-Cal population. But it appears that through this budget that they are going to cap that, which is going to result in a pretty significant cut. They are estimating that this will save the federal government $197 billion over that 10-year period. So it is the biggest single cut to the Medicaid budget, is capping and eliminating these provider taxes and these supplemental programs. It also, we were very fortunate as district hospitals that our directed payment program, this enhancement, we actually received CMS, the Centers for Medicare and Medicaid Services, that federal government approved that enhancement from $200 million to $800 million. They actually approved it this last February. The private hospitals, the children's hospitals, St. Agnes, Community Regional Medical Center, they are applying for their own directed payment program, but it hasn't been approved yet. It would be considered a new program. So it's unlikely that the private nonprofit hospitals in California, which are the vast majority of California hospitals, it's unlikely that their directed payment program is going to be approved. So and this is where the $197 billion comes from. So there are quite a few other provisions of this. One is now Medi-Cal beneficiaries will have to apply twice a year. So now they only do it annually, but now they're going to do it every 6 months. They're going to have to provide all the documentation that proves that they are eligible for Medi-Cal. and the government's banking on a lot of the beneficiaries will forget to do that, and they will be disenrolled, which will again cause them to become uninsured and save the federal and state government's money, but now it becomes the responsibility of the providers. This also looks like it will likely do away with Prop 35. So Proposition 35, the managed care organization tax that was passed overwhelmingly, almost 70% by California voters to support that. That is another form of provider tax that really was going to be funded entirely by the federal government. It means billions of dollars a year to California hospitals and doctors. What's interesting is through this federal budget, that program would have been killed. But at the same time, the governor has also, in his May revised budget, has announced that he is going to take 100% of that Prop 35 funds that the voters said, no, we want half of it to go to providers. The state, you can keep half for your general fund, but we want half of the other half, billions of dollars, to go to doctors and hospitals. Governor Newsom said, I don't care what the voters said, I'm taking it all for the general fund. So he just announced that last week. I think it's completely unlawful, and the California Medical Association of Doctors and the California Hospital Association probably already writing our lawsuits to stop that. But it may be a moot point anyway if the federal budget bill does not permit a program like the MCO tax from moving forward. So we don't know where the dust is going to settle. What it's going to mean. The details, still are to be learned. I think the California Hospital Association thinks that collectively this will affect hospitals in California by anywhere from $10 to $20 billion a year. It could impact CAUIA by as much as $60 million a year if all of the estimates from each of these cuts turns out to be the case. So now apparently chaos in Congress is our friend right now, because now, while this is passed the House on a one vote difference, this now has to go to the Senate and be approved by them. And we don't know what the likelihood is that it's going to pass the Senate. You may recall that the House first set a target of about $2 trillion in cost savings over the next 10 years. The Senate set a target of only $4 billion over the next 10 years. So an enormous difference. So if the mindset of the Senate is a much, much smaller reduction in savings, then I think this bill is going to have a very difficult time getting through the Senate. So the president wants it on his desk by July 4th to be able to sign it into law. Obviously, this is all to fund his tax bill, to keep in place all of the tax benefits and cuts that he put in place back in 2017, but also to provide more tax benefits really targeted to, I think, the middle class. No longer taxing tips, no longer taxing overtime, no longer taxing Social Security, earnings that are largely generated by the working middle class benefiting from these new tax provisions. But they're coming, at huge expense. I think even with the hundreds of billions of dollars in cuts that this bill contains, I think it also adds about $4 trillion to the federal deficit over that same 10-year period. So I'll take a breath.
Yeah, because so we're in budget season right now here at Kauai. In fact,
Yes.
Melinda is trying to finalize the budget. And with all of these unknowns, does it make it tricky, or are we still set for the next fiscal year?
Yeah, I don't think any of these provisions are necessarily going to affect our next fiscal year, which, just like the state, our fiscal year runs July 1 to June 30th. So our new fiscal year will start on July 1, 25. It doesn't look like any of the provisions of the federal budget will go into effect during this next fiscal year. So I guess that's the silver lining, is giving hospitals a little runway here, maybe 1 or 2, maybe 3 years to start putting in place how we expect to respond to this. You know, what services are we going to close? You know, who are we going to lay off? Frankly, we haven't begun to even fathom, you know, and every single hospital in California across the nation will be cut. Nobody's immune from this. We're all affected by it. So it's going to be devastating if all of this does in fact go into place. So, but you know, that said, even without any of these cuts, the state budget and $12 billion that he's got to close, he can't do that without touching Medi-Cal. So, this MCO tax that we're counting on doesn't look like it's going to happen. I understand that he's now going to start subjecting Medi-Cal beneficiaries to co-pays and deductibles at much higher levels, which won't be collected. It just means the state will pay a lower amount to providers and then look to us to collect those co-pays and deductibles from the Medi-Cal enrollee who's poor and won't pay them, and it'll just become a bad debt for us. So it'll save the state money, but just shifts the burden to the providers. So that's likely to happen in this next fiscal year, so we'll have to plan for that. But then just, the cost of labor right now, we have 150 travelers. There still is a huge RN shortage that's in place in California. So the cost of drugs, the cost of supplies, the cost of labor just continuing to go up. And so this, even without this federal budget, next year is going to be an enormous challenge. We'll work through it. We're going to work really hard. I doubt we're going to end up with a balanced budget. Just like the year we're in right now, we actually budgeted for a $12 million loss, and it's really FEMA. It's kind of saving our bacon. So we're likely, we're trying to give a pay raise. We're trying to fund 100% of our employer match to the 401k plan, but very, very difficult. But we're working hard. We will deliver a fiscally responsible budget to our board by the end of June. To have it might be just right up to the midnight hour, but we will get it done and look for our board to approve that budget right at the end of June to start the next fiscal year.
So this chat came in, which may or may not cause us to have a little bit of stress, but is the Hospital of the Future Committee ever going to meet again? That's the question. And 2030, I believe that was extended, seismic?
It is not.
So it's still looming.
Yeah. So yes, the Hospital of the Future Committee will meet again, but I'm waiting until I have something to share with you. Which that committee really came together, and it's been a phenomenal committee, and it's been given us great perspective and guidance. And I want to thank publicly all of our members again. And while we've had lulls where we took kind of a respite, whenever we were ready to share or seek input from that committee, they've all showed up. And so thank you for being on standby and still being involved. Right now, things have kind of gone dormant. There's really no activity that is occurring around the seismic issues, which again is kind of why that committee first came together, is to address that. But unfortunately, the bill that the California Hospital Association that was moving forward to provide some reprieve and extend that date. That was vetoed by the governor. What bill did pass was unique to small rural hospitals, critical access hospitals, and district hospitals to give us a 3-year reprieve. But that bill appears to be so onerous, I don't know if any district hospital is actually going to apply for that 3-year reprieve. Now, that doesn't mean that we won't be back at the table. We still have 40% or more of California hospitals cannot comply and will not comply with the bill as written. I am working with Kevin Morrison, who is reopening the whole SPC 4D option. And the committee members will remember that there is an option for non-seismically compliant hospitals like us to be able to apply for this special category called Structural Performance Category 4D. And that will require that all the interior of the hospital achieve non-structural performance category 5, NPC 5, but it would allow us to do more minimal work to the structure itself. So there have been changes to that category that we may qualify for. So we're going to bring back in our consulting firm or engineering firm to see if we might now qualify under that, and we will definitely bring that back to our committee when we know about that. So stay with us. We will convene sometime in this, probably the early part of this next fiscal year.
Okay.
Yeah.
So good things coming up. We've got GME new residents coming in this next month in June, a couple weeks.
Nice to end on a high note. Yeah. So June 10th at the Wyndham Hotel will be our GME graduation ceremony. We will graduate a little over 50 residents and fellows that have completed their training on their journey to become full-fledged physicians. So that's always a great evening to see all these young men and women, move their tassel over, so to speak, on their graduation cap. It's a great fun evening, celebrating with them and their family and all of our faculty and our program directors, our coordinators. So that'll be on June 10th. And then 1 week later, we will welcome a whole new batch of 50 plus brand new residents who are just starting that final journey that will join us. It's generally at 7 a.m. on a Monday morning that I'll be kicking off a new resident orientation with them. And that's a similarly fun event. So we're always excited to congratulate our residents. Hopefully as many as possible will stay here after graduation and continue to work and practice in our community. But then we're excited to welcome the new group.
Okay, fabulous. Well, we've covered everything, Gary, so.
All right, that was exhausting. Yeah, thank you for staying with us and through the thick and the thin. So definitely thin times lie ahead, which unfortunately is not new to us over these last several years, but really appreciate all of you, all of our community members that stay in touch with CAWIA and continue to root for us and speak on our behalf out there in the community, sharing the good things and the bad that we confront each and every day. But thank you for joining us again this month. Thanks for your great questions. And I hope you all have a wonderful weekend, Memorial Day, celebrating all the great things in our country and remembering all of our fallen men and women that gave the ultimate sacrifice for our freedom. Take time to think about them and their families, and but just hope you have a wonderful weekend, barbecues, and it'll be hot enough to jump in the swimming pool. And so have a safe Memorial Day weekend, and we'll see you back here next month.